Hey, everybody. Good afternoon. Thank you for joining us here at NewView for today's webinar. Your host today, my name is Patrick. I am the Director of Sales here at NewView. And I think as you saw in our waiting room, we put up a little bit of a graphic here to really kind of summarize the state of the industry at the moment, right? It's a lot of applications and again, a lot of work and volume at all of these locations, coupled with a reduced number of radiologist staff. So really we want to show you today how we can both help bring the browser swivel integration challenges kind of to a single kind of interface, while also hopefully making your radiologist more effective and efficient to help deal with that problem and give them a better reading experience overall. So let me share my screen here quickly. And then again, as we move through the presentation today, we'd like to encourage you guys to ask questions, make comments. There is a Q&A section in the interface. Please feel free to put that information in there. And then we'll be leaving time at the end to make sure we can address some, if not all of those questions live. And then we'll be sure if we don't get to your question today, we'll follow up with you via email as well. So let me go full screen here. I'm actually going to pause my camera. I will come back after I'm done. I talk with my hands and I don't want to distract myself or anyone else watching today's presentation. So let's get into it. All right. So again, I'm Patrick Skane. I'm the Director of Sales here at NewView. I'll be joined later in today's presentation with two of my colleagues, Dr. Addison McCaslin, our clinical AI advisor, who's going to give you some experience on the front end user experience of the NewView application. And then we're going to switch gears to our CTO and co-founder, Aaron McCaslin, who's going to take you guys through the back end of the product. Because as you'll see over the course of today's hour, we've not only provided a very interesting way to put work in front of the radiologists and information, but also a very novel approach in the administration and management of that process to really reduce the burden on IT staff. So a little bit about us as NewView. We are a new company, yes, but we are a relatively old team in the industry. So Aaron, myself, our CEO, COO, and a few other of our founding team members all came together in the early 2000s and built PureView, which became one of the first generation smart work lists in the marketplace today, which was then hence acquired by McKesson and Change and Optum, et cetera. But the message here is, for the last 2 decades, our team has been highly focused on workflow and operational efficiency around the radiologist workflow. And as the innovation was stalling with the old product and new technology, specifically cloud and AI applications, were coming to market and becoming more and more effective, we all got back together and rebuilt a workflow orchestration platform from the ground up. And this is what we're going to be happy to show you guys today. So in that first generation smart work list conversation, it really was about putting the right study on the right work list and having the radiologist find the right work list to read from. In NewView's second generation approach, we still want to get the right case to the right user. And as you'll see, we take a very different approach. We don't really have the same concept or need to use the same concept of work lists, but we put that right study in front of the right radiologist. But we take orchestration a step further. We also want to bring the right clinical context to the radiologist, as well as the right tools to the radiologist in a single interface, coupled with your viewer of choice, giving you essentially an all-in-one style overlay platform that solves some of the biggest challenges with radiology around that orchestration and distribution cadence of exams. And so why are we doing this, right? What's the cost? This is one of our customers' workstations from what we are working with. And if you look at it, it really is kind of a muddled mess. You've got the work list here, and that work list, and this should look very familiar, right? It launches stuff, right? It's managing integration bridges to things like EMRs and AI applications and note takers and chat tools and viewers and dictation systems, right? And your viewer. So even though whether they're getting the right case or not, there's a lot of places to go to find information and tools to interact with to be able to sort of report on that exam. So we wanted to start solving this problem, right? And our first pass is with our intelligent work list. So as you'll see in the demonstration later on today, we've taken the system from a rules engine style data fragile approach to putting things on work lists to an AI normalized user profiling approach, which allows you to very easily manage both complex data sets on the one hand, but also your complex radiologist skill sets, their credentialing, et cetera, right? Two big problems that we provide a very simple, intuitive UI to solve. And the result of that is we have the opportunity to give your radiologist a single curated work list, right? Instead of managing work from a dozen or so lists, we can bring that together into a single view based on clinical priority and also take into account that radiologist skill set as well in one easy, clean place. We're also aware of AI algorithms that might be running. A lot of organizations are investing in image-based triage applications today. We can also accept interfacing from those AI applications and use that data to prioritize and visualize studies on the work list for be able to leverage those investments both from a visualization in the viewer as well as on the workflow side of things. And like I said, as Aaron showed you, from an operational, how do you stand up a smart work list? I know a lot of folks that might have experience in the smart work list space know that it's a significant burden to constantly be managing rules and filters to achieve the outcome that best suits their radiologist staff. As Aaron will show you later on today, we don't have a rules engine. We don't have a concept of it. It's one of the core problems we sought to solve when we came to market again. And we're really excited to show you how we can produce a very similar, robust outcome that you might be used to interacting with without that operational overhead on the back end. And then as far as distribution styles, right, you don't bring a second generation work list to the market that doesn't do first generation things, right? So whether it's eligibility or shared work lists, distributing work by shifts or pools or seats, doing round robin equitable distribution, distributing work by case targets or RVU goals, these are all configurations within the system. And then it also includes your table stakes functionality, right? Being able to search for exams, interrupted workflow, chat and communication between users. We still maintain, right? I mentioned curated single work lists. You do still have the opportunity to build filtered work lists. Again, we'll show you our easy way to get there and also give you an opportunity to see with the user profiling where we can drastically reduce the need to have additional filtered work lists. We have very robust prioritization rules. And again, we're integrating with those third-party systems, and we can still maintain that legacy launch to things like PowerScribe and Epic and AI applications, et cetera. But again, going back to the state of the workstation, the work list helps, right? We can maintain those fragile bridges, but we're still just cleaning up one piece of the puzzle. And so what we've done to kind of take that orchestration layer further, like I mentioned, talking about the contextual patient information and the tools, we want to bring this kind of mess together into a single desktop. And how do we do that? We do that with our radiologist cockpit. So we're going to introduce this solution to you here a bit later on today. But this is really where we can take information from EMRs, we can take information from AI tools, we can embed generative reporting applications and clean up that mess and basically give that radiologist what they need to complete their work in a single screen at a glance in real time, hopefully making the whole process more effective on the front end for the end user and on the back end, reducing the amount of fragile integrations that need to be managed at the desktop. And again, the cockpit, this is your unified reading space. As Addison will walk you through today, this is going to have AI summarization of things like the historical prior radiology reports and EMR chart information. We have the opportunity, as I mentioned, to embed AI generative reporting tools so we can give it in a single screen. We can surface AI findings. And we also have the ability to build in things like peer review, follow-up workflow, critical results, technologist QC, resident workflow within this single screen as well. And it really allows for that sort of consolidated desktop, single screen, at a glance reading to help manage the burden of these large volume sites are facing today. So who do we hook into? How do we work, right? As being sort of that intermediary work list kind of cockpit overlay to your systems, we're driving other applications. From a viewer perspective, we are vendor neutral. As you can see, we've integrated with some of the bigger viewers in the marketplace. The middle of this slide here is the top half here is focusing on the EMR and scheduling system integrations that we've done, as well as some of the visualization AI applications for things like prioritization. And then on the right-hand side here, you see we pretty much integrate with every reporting solution on the marketplace. And as you'll see, we're actually dipping our toe and moving into that direction with some native reporting tools in the application itself. But really the message here is going back to the earlier slides. It's, our work list and cockpit plus your viewer, right? Or your reporting system of choice. We want to be flexible and allow you to achieve your goals. Quick snapshot of some of our customers here in the marketplace today. And we like to show this slide because it really runs the gambit from your very large multi-geographic reading groups down to imaging centers with some various size IDNs in between. Important things to note here, with many of these sites, we are replacing a variety of first generation solutions. So Lucid Health had a homegrown first generation solution that they had kind of built and brought to market, and we're having challenges with scalability and integrations. And they brought us in to sort of consolidate that stack and give them an easier path to bring value to the radiologists from an orchestration distribution perspective. In the middle here, Mayo Clinic, we are replacing a very complex Epic-based seat system that's being built in Radiant today, and able to reproduce that in a very flexible, intuitive way in the NewView application. Baptist Health is a smaller hospital system down in central Alabama. We're replacing their Philips PACS work list there and providing a great bridge for them to achieve some new goals around some of the prioritization challenges that they were having at the organizations today with some different varieties of urgent exams to be able to spread that work out amongst more users than being dependent on a single work list is one of the challenges they face there. And then Zwanger Paciri Radiology, as well as Geisinger Health System in Pennsylvania, we replaced the primordial first generation smart work list as well. So we're really excited. A lot of these organizations are seeing the value, and we'd be more than happy to chat with you more about the different reasons why they purchased the NewView solution and some of the problems that we solved. I'm sure that you guys will have similar things going on in your organization, so we'd love to chat about it. And then lastly, my last housekeeping slide here. So when we switch over to Dr. McCaslin, you are going to see a work list, and he is going to walk you through it as if this is his work. He's confident it's been assigned to him for the day. But this really gives you an idea of what's kind of humming in the algorithm behind the scenes to put that work in front of Dr. McCaslin. So the first piece, and of course, most urgency, is going to be sort of that business, contractual, or clinical patient-focused urgency reading, right? So clinical severity, integration with various AI algorithms, or exams that are coming up against an SLA timer. This is kind of the most urgent top of the list as it relates to the case, patient urgency, etc. Then on the right-hand side of the screen, you have what we call your administrative inputs, right? The what and how much should my users be reading? This is going to be the opportunity to integrate things with QGenda to be able to understand people's shifts. This is typically where RVU targets or case assignment targets are set and managed. This is also things like credentialing, insurance credentialing, referring provider preferences, etc. Right? The sort of the what and people and who should be seeing what. And then one of the fundamental changes, right? You heard me mention early on in the slides our unique approach to user profiling. But the radiologists, for the first time, when they log in, their skill set is traveling with them. They are actually part of the input into the algorithm. So what they can and can't read, what they like to read, is all built into their login. So anywhere that they travel and log in, that skill set is automatically applied in the system in real time and shows them the work that they're eligible to read. So with that, I appreciate you guys allowing me to do a little bit of housekeeping to sort of set the stage. But now I would love to hand it over to my colleague, Dr. Addison McCaslin, to give you the opportunity to see what the end user experience is as a radiologist.
Yeah, thanks very much, Patrick. That's a great introduction. And as Patrick said, I'm going to be walking through what you're going to see from the point of view of a radiologist. So I'm going to get a couple things set up to share the screen here. And as I'm doing that, I want to start by asking you a question. And I want you to think about what is the oldest, most out of date piece of software or technology that you still work with on a daily basis? And there's probably a lot of good options, let's be honest. I mean, there's so many things to pick. For me, one thing that comes to mind is I finished my fellowship in 2019, so a little while ago, but not that long. And when I left, I had to hand back my pager. And I don't know what's crazier is that we were still using pagers as our primary mode of communication, or that they wanted it back so that they were going to give it to the next person in line. And Patrick already mentioned that the ecosystem of applications in radiology is a muddled mess, but what's potentially just as important is that technology in medicine advances incredibly slowly, and most of us are using tools that are years or sometimes even decades out of date. And so we believe that you deserve to have a modern system with advanced capabilities that helps you provide efficient and excellent care to your patients. You need to have the right tools. So I'm going to share my screen here. Hopefully this is going to be coming through now. Can you guys see that? Okay, hopefully that's all right. So what you're seeing here, this is our radiology work list, and I think you got a peek at it from the slides that Patrick was showing. And from the radiologist point of view, this should all look fairly familiar, and it should be pretty intuitive what you're looking at here. You can see there's a list of studies. Every study has the type of exam, patient information, where it's coming from, all the sort of things that you'd expect here. You have multiple filtering options, all these sort of things. It's rank ordered in terms of priority. It's color coded by priority too. So you can see the red ones are the most urgent ones. And down you go the priority list. You can see how long it's been on the exam. You can even see other work lists that you have access to. So if you want to go select another one, you can do that. All your work is here in one place. And as Patrick mentioned, the purpose of the work list is without you having to think about it or having to do loads of upkeep, we get the right study to the right radiologist at the right time. And once I'm done, Aaron is going to go through all the clever customizations and tools and things that we have on the back end to produce this for you. But from the radiologist point of view, it should be pretty straightforward. You have the most urgent study at the top of the list. And so we're going to open that up and talk a bit about the cockpit. So whereas the work list gets the right study to the right radiologist at the right time, the cockpit is intended to give you the right information and the right tools to do your job. And our goal is to provide you a one-stop shop with everything that you need for your workflow. And before we dive into all the details and all the goodies that we have here for you, I have a confession to make. I am not actually a radiologist by training. I'm a neurologist. Now, that being said, in practice, I read all my own imaging, and I can't count the number of times that I see important or even critical findings that have been missed by the interpreting radiologist. And let me be clear about this. It's nothing against the radiologists. I work with excellent neuroradiologists. They're outstanding. But I have an unfair advantage when I read a study, and that's that I know exactly what's happening with a patient. I know what I'm concerned about, and I know where to concentrate my attention on the images. In other words, I have the clinical context, and context matters for accuracy. And we should be all aware of the consequences of missing or misinterpreting findings on a radiology study. Clinical workflows outside of radiology depend critically on the results of the reads. Most clinicians who are not radiologists are not carefully reviewing the imaging, and there's almost never going to be overriding what the radiologist says. So if there is an error, it's not likely to be reliably discovered. And the radiology report is the ground truth for what the imaging shows. So it's critically important to get it right the first time. So if context matters for accuracy, how are you currently getting the clinical context that matters for that accuracy? And too often, the real answer to that is you're not getting the context. Oftentimes there is an order form for the study. Sometimes that'll have some information. Sometimes it really doesn't have much of anything. It might just say pain or something like that. And it's up to you to go find the information that you think is necessary. And usually some amount of that information is available. So you can usually find prior radiology reports in whatever system you're working with, whether through PACS or whatever it might be. If you have EHR integration, often you can go look at other information in the chart. You can log on to the EHR interface, you can type in the patient's MRN, you can go to the right tab, you can sift through unstructured Word documents and spreadsheets, and eventually you might find information that's helpful. But the information is often hard to get to, it's hard to look through, it's inefficient, and we all know that the amount of time it takes for you to read the study is critically important. So we start at least by aggregating that data for you to put it all in one spot so at least you can find it. So we have our prior radiology reports. You can open them up, have a look at them. Great. If you have EHR access, we have all sorts of other data fields as well. You can see the patient's problem list, you can read through clinical notes, you can look at medications, surgical history, labs, pathology, you get all this information. But now we have a separate problem. We have all this information available. Great, there's loads of context, but now we're dealing with information overload. So yes, you can read through it all, but you still have the problem of it takes a lot of time to do that, to get all the context that you really want to have. And so, how do you solve that? And the great thing now is that we have incredibly powerful AI based tools to solve these issues with information processing. So, we leverage the power of modern large language models to summarize important relevant findings for you and present you with the information that matters. And we start by summarizing the past radiology reports because you're always going to want to know what has been seen in the past and what should I know about as I go into reading the current study. So we first gather the relevant prior radiology reports. We use our large language models, PHI safe, of course, to analyze what's present in them, aggregate those findings, and show you what we've discovered in a rank ordered or prioritized list. And so for this patient, who turns out to be pretty complicated, we see that we have restricted diffusion, or in other words, there was an active stroke on one of our prior studies. There was cytotoxic edema or brain swelling. There was narrowing of the left internal carotid artery. There was a subarachnoid hemorrhage. There were prior strokes. There's a lot of stuff going on. And it would take you quite a bit of time and effort to learn all this information on your own, but we hand it to you right up front, and all you have to do is scan headlines. If you want to know any more about what's happening with any of these things, we provide you a brief summary of what we see about that. So you can see for this narrowing of the carotid artery, it it's narrowed in the upper cervical carotid, and eventually there's minimal opacification, or in other words, it actually occludes as it gets into the head. And if you say, okay, well, fair, but where is that coming from? How do I know that I can trust this? And we provide the provenance as well. So you can see that turns out it actually came from the first paragraph of this report on the CT angiogram of the head and neck. So the AI accurately extracted that information and is showing it to you here. And this gets into a very important issue when it comes to using AI in any sort of clinical usage. And that is, how do you trust the accuracy? And maybe this is a novel statement, but for those of you who follow AI and understand some of its promises and limitations, one issue, at least in the past, has been things like hallucinations. Sometimes AI systems will generate an output that simply isn't true. And in healthcare, that's completely unacceptable. So accuracy of AI-based systems is absolutely critical. You have to be able to trust them, because if it ever does something that isn't true, you can't use it. So the first thing to say is that over time, the incidence of things like hallucinations are going down. Modern large language models are getting better and better at this, and it's intrinsically becoming less of an issue, but that's not good enough. So we architect careful guardrails to make sure that our system gives you accurate information. So that includes things like carefully defining our inputs, the scope of the analysis we're asking the system to do, carefully formatting our outputs. We include things like a temperature of 0 and strict JSON formats, for those of you who know what those things are. We ask the language model to explain its reasoning, so that we can see what it was thinking about, what it was working through. And we always make sure that we have provenance so we can go back and see where the information is coming from. We go even one step further so that you can look under the hood and see all the decisions that it's making. So up here, we have a tab that you can pull up if you're interested or concerned, that will show you all the findings that our large language model discovered from the prior radiology reports. So you can see there's more findings that were on the list here. You can see the body regions they're from, how severe or important the findings are. There's trend analysis, and whether the finding was included or excluded from the ultimate list. And you can see here, well, these findings were not included. And okay, we're reading an MRI of the head right now. So ground glass and nodular opacities in the lungs. Okay, fair. That was seen apparently on the CT angiogram of the head and neck. It caught some of the lung fields, but that's not relevant if you're reading a study of the head. So our goal is that over time, you'll come to trust the system, and you won't need to double check all this stuff because you'll get reliably accurate results and you'll see the value. But if you don't trust it, we always want you to be able to see where the information is coming from, to be able to verify what it's doing. So there's never any black box. And if anybody's interested in any further information about what we're doing with our prior report summarization process or anything else we're doing, we're happy to set up a time to talk more detail. If you have a case that's not this complicated, say it seems to be relatively simple, and there isn't necessarily loads of prior context, we also give you the peace of mind to know that you actually have all the context that is necessary. And the other part of that is it can be hard to know when there actually isn't any relevant clinical context. So let's say you're reading a chest x-ray for a young, seemingly healthy person, at least not obviously with anything going on. Well, turns out they might have a history of HIV or might have had TB in the past. And it's very important to know about that as you're going to read their study. And that gets into the next level of information that we can provide to you. So for everybody, you should have access to relevant prior radiology reports. So we can always provide that as a service to summarize those. But if your organization has integration with electronic health records, we can do so much more for you because there's more clinical data to analyze. And a critical piece of information that we would always want to know about is what medical problems does this patient have? And what do we know about them? And if you have EHR integration, there is a problem list. You can pull it up, you can look at it. But similar to the app ecosystem, it's a bit of a muddled mess. So yes, the problems are on here, but they're not organized. The list is not necessarily kept up to date either. And there can be important stuff buried in here that's easy to overlook if you're not carefully examining what's here. If you scroll down, oh, look, it turns out this person has metastatic cancer. There's 4 redundant entries, but here it is. So very important to know, but it's not made immediately obvious for you. So we'll also look through the problem list, we'll look through clinical documentation, and we'll summarize the relevant patient problems for you. So we'll prioritize what seems to be the most relevant to the current examination. We'll summarize the information that's known about them, and we'll present it to you here. So we see some things that were alluded to, like prior ischemic strokes. The patient's encephalopathic right now. They have that carotid occlusion. Here's your metastatic cancer. And here's one called disseminated intravascular coagulation. For those of you with any clinical background, that's a serious problem, can be life-threatening even. And it turns out that this actually was not present on the patient's problem list. this is being extracted from the clinical notes. So it also helps to get around the problem of the patient's problem list not being reliably updated. So we make sure that you have all the information that you want to have here. Now, this clinical context is wonderful, should be extremely helpful, but often we want to know just why is this study being ordered in the first place? And so that brings us up to the top here, the first thing that you look at in the UI. And first off, we'll give you the reason from the order form. And in this case, it's actually not too bad. They want to know about looking for strokes or other things because the patient's sleepy. But a lot of times the information in that order form is pretty sparse. Again, it could be pain, it could be blank. You might not really have anything to go with. And so we provide not only a basic reason, but if you have EHR integration, we'll go through the available documentation and try to figure out for you what's going on here and what really is the reason for why this study is being ordered. And it starts with what we're calling high-level reasons for the study. Most or a lot of radiology studies are done for diagnostic purposes, as this one is, meaning that you're trying to figure out some clinical presentation for the patient. They're having symptoms or whatever, you want an answer. But not all studies are done for that. You might have a study that's just scheduled screening for some problem. You might have preoperative guidance study. You might have a post-operative follow-up or hardware evaluation. You might have a trauma study. But for diagnostic purposes, we'll give you what's the current clinical presentation, what differential diagnosis are people working with, and for head imaging, we'll even give you a tentative localization if that applies. If this were a trauma study, though, you would want to know different information, such as what's the mechanism of trauma that we're aware of? Is it blunt, penetrating? Is it a gunshot? Is it a crush injury? Whatever. What parts of the body have been affected, and what do we know about the trauma so far? So we want to give you that clinical context that sets the stage for you to read the study effectively. And at this point, you should have all the context that you need to confidently go and start producing your report. But if there's anything that we've missed, if there's anything that you're still not clear about, we have one more tool that we're excited about to help you learn about patient information, and that's Eric here. Eric is a large language model based assistant that has access to all the information we've extracted from your systems. And you can ask any question, you can use it like any large language model. But what's powerful is that you can ask it a question specifically about the information in the chart. So for example, if you want to say like, hey, is the patient on blood thinners? This query will go to the language model. It'll say, oh, you're asking me about chart information. I need to pull up the medication list. I'm going to look through those. And turns out, yes, the patient is on blood thinners. They're on apixaban or Eliquis. So great. And you can ask all sorts of things. You can summarize the hospital course. You know, the sky's the limit for what you want to know about here. So now we have our clinical context and we're ready to move on to the radiology report. So we're excited to be building a reporting solution. We're building a generative AI solution. So in other words, you dictate the findings into our text box and AI will take care of the rest of the report. So for example, hopefully the microphone is working okay. There is a large area of restricted diffusion in the left frontal lobe consistent with acute ischemic stroke with mild associated cytotoxic edema and 2 millimeters of left to right midline shift. And so as I dictate this in real time, we're sending the information through analysis that'll strip out filler words and correct punctuation, make sure that the transcript is accurate. It'll parse the content and determine where in that report things should be inserted. So you can see all the purple highlighted stuff is where we've inserted contents into the report. If there's normal findings in there, we'll either remove or modify those. And in the bottom, we'll generate an impression for you. And we're excited to be building tools as well that customize the impression so that it presents in your voice and appears in the way that you want. So we're very excited about generative reporting, but this is not required. We absolutely recognize that not everybody is excited about generative reporting. A lot of people just want to put their cursor somewhere in the report, dictate, do their job, go field by field. That's fine. So we fully support you being able to dictate in the way that you wish. And our entire philosophy is we want to give you the tools you need to do your job, that we adapt to you rather than forcing you to adapt your workflows to us. So we want to make everything very easy for you. And the last thing to say is that with our cockpit, our goal here is to give you all the tools that you need, but we also recognize that depending on your organizational structure, you might not need or want every tool that we have to offer. For example, if you don't have EHR integration, then you don't really need the relevant problem summaries and the expanded purpose of study and things like that. So that's totally fine. Our services are modular. So you can get the prior radiology report summarizations. You can get the expanded EHR things. You can get reporting, or you can get some of it or none of it. Our goal is to give your organization the tools that it needs. And so with that, I'm going to hand it over to our amazing Chief Technology Officer, Aaron McCaslin, who's going to dive into all sorts of very clever and innovative solutions that we have on the back end.
Awesome. Thank you, Addison. All right, so I'm going to share my screen here. Hopefully that is visible to everyone. Looks like it worked. All right. So I'm going to cover a little bit of the magic behind the scenes and some of the core tenets of the application and the platform that we felt were really important to bring into this space, and some of the problems we're trying to solve and how we do that at a more granular level. So Dr. McCaslin did a very brief introduction of the worklist from the point of view of a radiologist. And I think he very appropriately highlighted the ease and simplicity of use, right? So you have your navigation on the right. Everything is sorted by priority by default. It can be customized by the user with drag and drop. You can sort and filter, all the standard worklist things you would expect. We don't want this to be a jarring experience from the point of view of training and adoption, and force people into models and tools that they're not comfortable with, right? So from the point of view of the radiologist, it's very straightforward, right? Your work is presented to you in order of priority. You're able to search and filter. You know, if I'm looking for a patient, you have free text search and all sorts of, simple stuff like that. So those are kind of the baseline. But as a philosophy, we feel very strongly about making it very visual so that we reduce the mental burden on anyone who's using the application in terms of what's happening with an exam, and making it very easy to personalize or change your settings with 1 or 2 clicks, right? So I'll highlight a few things around visual indicators, and then we'll get into some of the configuration, because the real magic happens kind of under the covers. And that's how we present the simplicity to the end user, by managing the complexity kind of behind the scenes and making it actually simple to manage that complexity. So I'll highlight a couple of things around visual indicators. So for example, if you're using an image analysis AI like Viz in this case, or ADOC or River, that there's an indicator that I can see at a glance which exams had algorithms run, and did that impact the priority, right? So you have a suspected positive, which can increase the priority of the exam, or you can have a suspected negative, which is still flagged as there's an algorithm that was run on this exam, but it may, as a suspected negative, hasn't had an impact on the priority, right? So you have a lower priority exam. You can, as Addison highlighted, you can navigate, you can kind of customize the UI how you want. So you can have multiple work lists open. You can use these for counts and monitoring. And you have simple settings here in terms of changing your preferences. So if you want to do auto next, kind of back-to-back reads, and effectively really not focus on the work list, which ultimately our goal is to keep you focused on the current patient, the current images, and the interpretation process, right? To make this part of the application so accurate, reliable, and efficient that it becomes more in the background and you're really focused on the patient. So you have simple 1-click settings here. Now, in order to get all of that happening, I'm going to switch to a more administrative view. So I'm a radiologist. I'm going to switch to some of the administration, the configuration, to highlight and solve a simple configuration problem that is generally faced by almost any radiology department in any working environment. And we'll go through a practical scenario. So here you see there's a whole host of other options available. So some simple ones like a manual assignment and changing the priority, kind of, again, standard interaction tools you'd want from an administrator or from a radiology support staff person, right? We have visual indicators for, is this exam ready to read? So we have this concept of passing gates or checks for what exam is appropriate to put in front of a radiologist. So you don't want the radiologist seeing final exams, scheduled exams, but how do you determine what the appropriate status is for reading? So we have these 4 checkboxes that say, has it been turned off for some reason? That's kind of uncommon, but there are settings in the application say we don't read those exams, so I'm turning them off. Is it in the right risk status? And you get to choose which those statuses are appropriate, but is it ready to read? Has it been completed in the risk? Are there images in the PACS, right? Have we, part of our goal is to make sure that you're able to leverage your existing investments in the viewer space. You're able to continue to enjoy those investments and not do a huge rip and replace with image migrations. So we interact with the PACS at a very granular level to understand when the images get there. And so we know that when you launch this exam, you're going to see something. And then finally, has it been reported? So we integrate with all the dictation platforms that are there in the marketplace, really, to make sure that we have desktop level integration to make sure that updates and information is pushed to the work list in real time. So there's no refresh rate, no delays, right? Visual indicators for locking. This exam is currently being reported by me. And that allows us to manage the system in a very effective way because I can simply look at I can toggle from an administrative perspective. I can see all exams the system knows about and adjust the status of those. So for example, if a notification from the PACS fails, but you know that images are there, I can actually override that as an admin and say, you know what, I need to push it to the radiologist and not have to troubleshoot the root cause right away. I can solve that in a more timely fashion. So lots of tools around visual indicators and ease of administration just from the day-to-day operation. So just covering kind of the basic things there and some of the important things. But that's not really where the magic happens. So we wanted to tackle a couple of key foundational problems with systems in this market space, with the workflow orchestration platforms. And the first problem we wanted to tackle was that in general, when you're setting up sophisticated or complex workflows and distributions, and you're trying to achieve different kinds of outcomes, whether that's highly specialized reads, that's load balancing, that's equitable distribution, that's reduction of cherry picking, right? Those are all goals you have for your radiologist and your radiology departments, right? You're trying to accomplish productivity, you're trying to accomplish fairness. But in order to do any of those things, it's really critical that the application understands what an exam is, right? If you don't know what specialty or body part it is, you're not going to be able to distribute that to the right person and to do all of those more advanced things. So you have to start with the basics. And we wanted to tackle the problem that arises all over the industry of changing data. So that can be you have multiple ordering systems with different exam codes, different wording for the procedures, or you can have a single system that has new procedures added, deprecated, or changed over time, or just simply mistakes and typos. All of those things, and those are routine events no matter how big or small your enterprise is, that need to be managed from a workflow system that if you add a new procedure, or you have multiple procedures across multiple ordering systems that are all the same specialty or body part, or the system has to know about that. And that usually is managed through dictionaries, translation tables, and a lot of manual investment. And to add a workflow orchestration system to your technology stack, you add another layer of burden of mapping that along with your hanging protocols and everything else. So we wanted to really simplify that, not just for the ease of implementation and management, but also for the consistency of performance. Because if you don't do those steps, then the system will drift and become less and less accurate over time as new data comes in and needs to be updated. So here, what we do is we use an AI normalization process on the wording of the procedure. So plain English, the name of the procedure as we process that. If we haven't already done an association to our normalized catalog, this is our normalization procedure, we use a combination of deterministic logic and LLM-based AI to select a normalized procedure from our catalog in order to standardize the configuration. And so our catalog, a little bit about our catalog, it's quite comprehensive. We've invested heavily in that. It's broadly based on the Radlex RSNA catalog of radiology procedures. It's been cross-referenced with the CPT code list of radiology applicable CPT codes. So, and it spans about 8,000 procedures. And we work with our customers to make sure that we are staying up with a curve of new procedures, of custom and bespoke research procedures. So we put a lot of work into making sure this normalization process is accurate, efficient, and up to date. And so the way that that works is quite straightforward. So to take one of these examples, you can see here, you have a CT chest / PE W/C, right? That's been normalized to a CT chest with contrast. So we're taking the abbreviations, but there's lots of different ways of saying the same thing, right? So, and you can have different ordering systems that use the same language, and you can have variations in language. But even in a very simple scenario, let's say that, for example, right here, you can see this 3T. Let's say you acquire a new MRI and you update the risk because you want to book your new coil and you want to book those rooms separately from your other machines, right? So you add a procedure, and now I have to update all of the mappings for specialty and body part that correspond to my new procedure description, even though this is maybe the same as an existing one, that the system automatically translates that and does that normalization behind the scenes so that it doesn't need to create a disruption in the workflow. And after we do that normalization, what's so important here is it allows us to take a standardized framework for specialties, body parts, RVU, prior relevancy. We can take that catalog and create a consistent framework for each customer. So you have complete control over what your specialties are. So which exams fall into which specialty, how many specialties there are, different specialties for different radiology groups, et cetera, et cetera. So there's no limitation on that configuration. And similarly with your body part categorization, right? So we provide a default, but then you can edit that. So you have complete control over the configuration. But by doing that normalization process, the system is naturally resilient to changes, data, onboarding, to typos and mistakes, right? So, you can see an example here where this procedure has 7 or 8 apostrophes, probably not intended, could be a typo. The system can catch that and make sure that that doesn't disrupt the reading process. So very, very important foundation. But what do we do with all that? So we start with fault tolerance and resilience in the management of just processing orders and processing exams. But then we wanted to tackle another problem. And so this will lead us into our workflow scenario here that I'm going to solve a very common radiology configuration problem. So to tackle this problem, and I'll turn it over for Q&A because there's lots to talk about, we wanted to make sure that when you're setting up even a very simple work list and even tackling a simple problem, that you often have problems with configuration because you're trying to take into account the skill set of your staff, right? And so to solve a simple problem like you have 2 radiologists who both read ultrasound, but one of them doesn't read prostate and thyroid procedures, which is fairly common, we wanted to make sure that the user is a component of any filter set that we use when we're configuring the application. So number 1, we talk about data management fault tolerance. Number 2, we want to introduce the concept that the user is a component of the worklist filtering themselves. And so to close that out, what we do is we profile the users in a simple centralized way. So you can see here, what modalities do my staff read and not read? What specialties do they read and not read? What facilities do they read or not read for, right? So credentialing is built in at the base level to the core functionality. And then to tie that together, to solve that problem with the prostate and thyroid procedures, a traditional solution might be one of 2 things. You can make an all ultrasound work list and have one of the staff ignore the exams they don't read, but that leads to clutter, that leads to mental burden, and causes problems with workflows like AutoNext. The system has to know that you're not going to read those, so it doesn't give them to you, right? So there's lots of issues with that. A more common solution would be that I have to make two work lists. So I have all ultrasound, and I have the ultrasounds without the prostate and thyroids. And anytime a new procedure comes in for one of those body parts, I have to go update my filter set and maintain that. So to solve that problem, and this is the most basic functionality, but a very simple and understandable one, we're going to create an ultrasound work list, which I've just done. Very simple, reliable, sustainable filter that doesn't need maintenance. And then I'm going to draw your attention down here to the lower portion of the screen where we can apply a filter set to this based on that user profiling I just showed. So if you want to omit body parts that the current logged in user doesn't read, I simply check the body part box. And that will then customize the work list for body parts. If I want to omit specialties they don't read, I simply check that, or facilities. So any work list can have these toggles enabled or not, right? So if you want to have a list of everything that has no filters, that's perfectly allowed. But this allows you to create highly tailored lists in any context that says the user will only see the exams that they should be seeing and want to see without the need of a lot of maintenance and configuration. And then that leads us into some of our more advanced round robin distribution and algorithms where we can apply that in a more ongoing real-time basis. But even when you're solving simple problems, the application really allows an obvious, visual, and streamlined way of configuring and maintaining those systems. So I'm going to pause there. I've run over a few minutes into our Q&A time. We have just wanted to give a little bit of a taste around how we do things, some of the core functionality, different approaches to ingestion, data management, configuration, and maintenance, making sure that it's visual, that it's obvious, and that it's not too complex for your staff to maintain. So are there any questions or comments I can address? Let me check the...
Yeah. Hey, Aaron, great, amazing job. We did have a couple of questions come in. One that came in that I definitely hear a lot out in the streets is around multi-vendor environments. So organizations, whether through acquisition or just by nature of design, that may have multi-PACS systems potentially in place, or a reading group that's reading amongst different systems. The question is how would we approach, or can we solve some of the problems with consolidation around those types of environments?
We sure can. Yeah. So thank you. So we took a very flexible approach to integration, and we were considering large enterprise scale deployments right at the outset. So the way that we're able to integrate with multiple platforms is very straightforward, right? You can have one or more viewers, one or more voice recognition systems, and other integrations. So you can see we have QGenda here, but if you want to launch Epic, then there's a configuration to add one or more Epic configurations. And if you want to have two of the same viewer, that's perfectly allowed as well. And one of the things that is important here, so if I want to set up, say, a PowerScribe, I simply, I give it a name, PowerScribe from General Hospital, and I choose what exams are associated with that, right? So I can say the exams coming from this RIS or this EMR, launch this PowerScribe, and the exams from this RIS and launch Fluency, right? There's no problem with that. But it's also easy to change. If you want to swap in and out a reporting application, all you need to do is associate that integration to those orders. So that we call it assigning authority, but that's essentially the identifier of the risk. Similarly, with viewers, you could say I have 5 viewers set up, or 2 or 3, and these exams, it's basically where do those images live? What orders are associated with those viewers? So very, very easy to scale up or to even modify or to try out different voice recognition systems, something happening with the end of life of PowerScribe. We're kind of future-proofed in saying, like, you want to swap your PowerScribe for another application? No problem. We simply fill out the integration for, say, Rad AI, and you're off to the races. But they're a very easy, very visual, very flexible way of managing multi-vendor workflow. And those can be aggregated into the same work list or separated between work lists. You can launch those applications on the same desktop, as long as you're beholden to the restrictions from those. So two power scribes don't play nice in the sandbox. But generally speaking, with some of the newer applications or different vendors' products, there's no issue at all.
Fantastic. That's awesome. Another one that came in, does the system support radiologist peer review?
Sure, it does. Absolutely. So we have actually, I've got a system set up to show that. So we support a couple of different models of peer review. So I've launched some images there. I've got an embedded rad pair, so a different working model. So you can see kind of a different way of working, prior report here. And the peer review functionality, this is ACR compliant, so we do randomized peer review, and we also do on-the-fly peer review. So if you see something on a prior report, we're presenting that prior report here, and we're either asking you to do a peer review at a randomized interval based on the configuration. So you have a lot of knobs to turn about who participates, how frequently, takes into account their specialties, doesn't do their own reports, all that good stuff. But that's integrated right into the cockpit or into just the work list. So it's supported in any working model that you choose in our application, but very straightforward. You simply complete the form, submit, and that goes to a dedicated follow-up queue for your senior radiologist, your QA committee that needs to review those and adjudicate any discrepancies. So the discrepancies are automatically sent to a follow-up list. But there's a comprehensive peer review suite. That's our pedigree from peer review. And we wanted to make sure that we baked that in as part of our overall suite of tools.
It's fantastic. Very close to time. One more that seems to be kind of a market timing sensitive question based on some of the newest news coming out of PowerScribe here recently. But one of the attendees asked that or mentioned we're working on a reporting module. And so the question from the attendees is when is that something that becomes available?
Great question. So very prescient right now with the end of life announcement. So we had started on this journey about 6 months back or more. So we've been working on this quite a while under the covers, but we're at the point now where we're moving into alpha and beta testing over the course of the summer. And we're targeting a release in the early part of next year for GA. And we are actively inviting folks who are interested to help us with validation trials. We're working with some of our install base on that. So you can see here, we've embedded that right in the cockpit. We're, as Dr. McCaslin highlighted, we want to support a transition from PowerScribe. So for those people who are not interested in using a new model, but need another tool that's going to be as fast and efficient, we're going to make sure that we manage that transition as well. But the timeline is early next year. So it's a great time to get in and help us either test it, or if you want to evaluate it, or to give feedback. We are actively recruiting folks for that. We'd love to have people join in and help us.
Well, that's fantastic. Well, thank you, the McCaslin bros, Dr. McCaslin, Aaron. Thank you guys so much for this fantastic walkthrough of the application. I hope everyone hears we're all really genuinely excited about what we're doing here at NewView. You will get a recording of this after today's session. There were a few additional questions that we were unable to get to live here today, so we'll make sure that we follow up with those individuals directly. And then by all means, feel free to find us on LinkedIn, online at newview.ai, and make sure you spread the word. We're really excited here, and we all appreciate your time today. So thanks, everybody. Have a great afternoon.